Hello, I'm Helen. This presentation is about the methods for conducting economic evaluation of services supporting infants, children and young people at the end of their lives. I'm pleased to present this work on behalf of the fellow co-investigators on a project on end-of-life care for infants, children and young people. It's a mixed methods evaluation of current practice in the UK, and for short we call it the Enhance project. I'd also like to acknowledge the study funder, that is the NIHR, HS and DR. This provides an overview with the aim of understanding where we are now with our thinking on economic evaluation methods in this field. The presentation contains 5 parts. Firstly, background as to why we're doing this research. Secondly, the role of economic evaluation generally. Thirdly, a quick review of the key steps for undertaking an economic evaluation. Fourthly, to think about the methods for incorporating economic evaluation in end-of-life care in children. This includes the methods guidance and the conventional NICE framework, as well as the methods needed specifically for undertaking economic evaluation in end-of-life care in children. And finally, in relation to where we are now, a summary of the methods used to date and recent methods developments for consideration. This slide covers the background by way of starting point. So we see that increasing numbers of paediatric palliative care and hospice services are available in the UK, caring for the some 5,000 children who die in the UK every year. In 2016, NICE provided guidance for end-of-life care for children, and there were 2 key highlights. One was that there was inconsistent and varied provision of care, and secondly, that there was limited evidence on end-of-life care models and relevant costs and outcomes. So the aim of Enhance is to assess the resource implications and outcomes of different models of end-of-life care for the NHS, the children and their families. This slide provides a brief reminder of the role of economic evaluation. Economic evaluation considers the costs and the outcomes of 2 or more comparator interventions to assess their relative merits. The aim of it is to support transparent, consistent and accountable decision making, and economic evaluation provides a decision aid for decision makers. When looking at the literature, Matthew et al. In 2020 did a review and only found 5 published studies in the area and none in children. So this absence of cost-effectiveness evidence reduces the opportunity to make effective use of resources, and this has negative impact on the children and their families. So what are the key steps in economic evaluation? Firstly, we need to identify what we're comparing, and we need to think about the perspective that counts, and this would be involving considering the funder of the care, who delivers it and who pays for it. Also to consider the outcomes and the costs to measure and how, and the perspective guides us on this. And lastly, to make broader comparisons, for example, whether we consider costs and outcomes across other similar individuals or even across the broader health and care system. Having considered the key steps in economic evaluation, it's useful to look at NICE's conventional framework as a starting point. Here the aim is to maximise QALYs, that is quality adjusted life years, for the individual over their lifetime, with QALYs being made up of health related quality of life and life expectancy. Turning to costs, the resources and budget of relevance when costing these services is the NHS and personal social services. Another important consideration is opportunity cost, and under the conventional framework this is the health opportunity cost. This considers the foregone benefits in terms of health no longer achieved through using the standard intervention and redirecting funds to fund the new intervention with its own set of health benefits. If the new intervention achieves more QALYs at an additional cost, there is then a question about whether the additional cost is worth it, and the approach assumes that the additional cost is absorbed, but with some unobservable opportunity cost. Another consideration under the conventional NICE approach is that a QALY is a QALY is a QALY, no matter to whom it accrues. It should be noted here too, however, that NICE used to have end-of-life criteria for life-extending end-of-life interventions, which was about giving extra weight to a QALY at this stage. A recent consultation on methods has taken place, however, and some severity modifiers have been introduced. This slide considers the economic evaluation framework and its applicability to the economic evaluation of end-of-life care. Here we're considering what objective are we trying to maximise. Should we use the conventional QALY to be the maximum? Should we stick with generic preference-based measures to allow us to compare cost effectiveness across other conditions within healthcare? And what about specific preference-based measures? Would they be more sensitive? And what are the implications of using them if so? The QALY is based on a utilitarian approach, but this has been questioned. Should we instead consider other approaches, such as that offered by Coast et al., who have developed a capabilities-based approach? And they have produced the ICECAP supportive care measure, the ICECAP SCM. And this approach covers a range of attributes found to be relevant in end-of-life care, such as choice, dignity, and being supported. We could instead consider composite approaches such as cost-benefit analysis, where the outcomes are monetised, or cost-consequence analysis, where a range of consequences and outcomes are quantified and presented in a disaggregated format. We can also consider whose outcomes, how to measure them, whose values, and how should they be valued and when, a whole load of different other questions beyond the maximum. And also to consider the relevance of distributional cost effectiveness analysis. And this information is about the equity impacts of interventions and the trade-offs that sometimes arise between equity and efficiency. And there are lots of unresolved issues here that we might want to consider more. To undertake economic evaluation, we also need to consider which costs are relevant in end-of-life care. And it might involve care beyond NHS provision, for example by hospices that only receive about 20% of their funding from the government, also charities and family costs such as out-of-pocket costs and costs to access care. So we might look beyond the conventional framework by NICE to their broader set of methods guidance, in which non-NHS and personal social services costs are permitted. And there's also the idea that if it's relevant to record it, we should do, and don't assume that things are just equivalent. And also to consider really the sort of full social implications of providing an intervention. And we consider really how to assess costs and whether they are available or not. For example, considering NHS equivalent care and parental consumption. Finally, and most complex of all, is what is the opportunity cost in end-of-life care? That is, what are the foregone benefits? If we invest in a new intervention, say intervention X, what is displaced in terms of health and resource elsewhere in the system? And the additional costs do not just displace care within the NHS, but potentially on other sectors too, such as social care, the voluntary sector, and families, and not necessarily in the same direction. So for example, there might be an intervention that saves NHS resource but actually costs more in terms of hospice costs. There are other things to consider too that are related, such as the impact on others, for example non-patient quality changes at the margin, and as I've said before, whether or not there should be some kind of adjustment when we think about end-of-life care and its opportunity cost. This slide covers where we are now in terms of economic evaluation and end-of-life care methods that have been proposed thus far. Normand and May are health and care economists. They've published a number of think pieces and end-of-life assessments in the area, and among other things they flagged that the use of QALYs and the measuring of patient benefits might only risk creating a sort of perverse incentive or a myopic view of health when conducting an economic evaluation of the relative merits of competing interventions in this field. And if we turn to the NICE guidance of 2016, they flagged that there were only 2 relevant studies in the area, and these focused on costs. So if we focus on costs only, however, what's the implication of this? Well, this assumes the equivalence of outcomes across comparator interventions. So it might be questioned as to how possible it is to achieve Dienberger's et al.'s aim of reducing the financial burden of care of the dying on the healthcare system without considering the level of care or a person's quality of life. Further to this, York Health Economics Consortium undertook a return on investment analysis of children's hospice services in Scotland, and this approach involves monetising the outcomes. However, there is a debate about whether or not this approach really fully incorporates social value and opportunity cost. So in terms of other options, well, obviously we can consider the novel approach suggested by Coast et al., and this might be a relevant alternative framework to consider. Another approach to consider, which can be seen as building on the conventional NICE framework and the broader NICE framework, is the impact inventory approach. Walker et al. Extend the impact inventory approach that was originally developed by the second panel on cost effectiveness in the States, and there they consider all affected individuals and reflect outcomes attributed to an intervention which can be compared with outcomes foregone as a result of resources not being available for other purposes. These assessments reflect the institutional arrangements of public bodies, for example, their funding, the outcomes they consider important, and their relative valuations of these outcomes. They inform multiple decision makers, whether public bodies or broader, and who may have different objectives. And the aim is to provide practical guidance on overall societal impact. So really, I suppose it accepts that perhaps a single social welfare function is not realistic to add everything up together, but it's also perhaps a rejection of the sort of cost consequence approach where there's this might be considered an oversimplification where opportunity costs are not reported, and in practical terms it's pretty kind of data heavy, but I think it provides a useful approach nonetheless. So where are we up to generally in this field? Well, there are no quick fix solutions to obtaining a meaningful evaluation in this setting. There are really rather lots of questions to be asked, which does imply the need for further research. So I think a lot of these issues, they're not especially unique here, but they are extensive, and there are really fundamental principles of economic evaluation are still very useful and very flexible, but they need defined inputs. And as health and care economists, I think, you know, we sometimes it's okay to go for sort of second best, and certainly it's very useful to use the engagement of parents and patients by experience in this field. I mean, overall, it's just important to be clear about some of the challenges that we face in this area so that we can better put ourselves in a position to navigate evaluation in the field, and to do our best to quantify and inform the multiple decision makers who may have different objectives, but having the ultimate aim of doing our best in terms of developing the evidence base for these children and their families. The key question that I began this presentation with is, are we there yet in terms of selecting how to undertake economic evaluations in the area? I would say that probably not, as there are still many issues to be resolved. Traditionally in economic evaluation, we focused on cost effectiveness analysis, but there is a question as to whether other approaches such as CCA or CBA might be useful, or to step away from these altogether. And also the question on whether impact inventory assessment might help us. We're used to dealing with budgets that are siloed and the use of QALYs, albeit flawed, and the need to consider different opportunity costs across sectors. But of course, if there is more integration, this could change. Perhaps instead we should consider alternatives such as the capabilities approach. Another aspect of this is to consider the use and value of using distributional cost effectiveness analysis alongside economic evaluation in the area to better understand health inequality impacts for different subgroups, for example. Also, we might like to think about going beyond incorporating outcomes for the child. There are issues with this to consider. For example, a child with a greater number of people in their close network might accrue relatively more benefits. But in summary, the aim of highlighting these questions is to give some insight into some of the many ongoing questions and issues we need to navigate in the field. And finally, this slide gives some key references that were used in compiling this research. Many thanks for listening in. I look forward to seeing you in my session, which will be presented on the morning of the 7th of July. Thank you very much.